Thanks everybody for joining in to our first ever session for the AMSA PACES Essentials series. My name is Chang, and I'm sure most of you will know me by now, but I'm one of the fifth year medical students at Imperial, and I'm also the Senior Years Academic Officer for our society. Today we have Dr. Fredrika, who has kindly given up her evening to give us a tutorial on the kinds of obstetric emergencies that you will need to know about and the ones that you'll want to master before you start your foundation year rotations.
Hi everyone, thank you so much for joining, and I hope you've had a good start to your fifth year so far. And thanks Chang for introducing me as well. So as mentioned, I'm a foundation doctor. I'm currently at Northwick Park, and I've been asked to do this tutorial on obstetric emergencies because I've recently completed a PhD in fetal growth restriction. So I'm coming into obstetrics from an academic background. So today we're going to discuss obstetric emergencies, and let's get cracking. So the key things we're going to discuss today are the risk factors and management of shoulder dystocia. We're going to have a look at preeclampsia, eclampsia, and HELP syndrome. Don't worry if you haven't heard about any of these before. We're going to discuss postpartum hemorrhage, both in terms of risk factors and management. And we're going to briefly touch on placenta previa, vasa previa, placental abruption, and umbilical cord compression. Okay, firstly, let's discuss shoulder dystocia. Yeah, so shoulder dystocia, just as mentioned, it describes this problem where the baby's head is delivered, but then usually because the baby is large compared to the circumference of the mother's birth canal or pubic opening, the baby gets stuck with the anterior shoulder behind the symphysis pubis. So you can see there in the little picture, the bone, which is colored in blue, that's where the baby's shoulder gets stuck. And sometimes in these situations we refer to the baby showing what's called a turtle sign, which is when the baby's head is delivered but then actually pulls back into the birth canal afterwards and kind of pops in and out with each contraction but doesn't get any further. That's the turtle sign. And the absolute key risk factor for shoulder dystocia is macrosomia. So this is a condition that is increasing in prevalence with things like gestational diabetes and type 2 diabetes becoming increasingly prevalent. So large for dates babies have a higher risk of becoming stuck and shoulder dystocia to occur. All right. And as you can understand from just looking at the little picture and thinking about how much extra force it will take to pull that baby out, sometimes it is associated with brachial plexus injuries in the newborn. For example, Erb's palsy, which I've shown there in the picture, this classic situation where the arm is extended and the hand is flexed and pointed backwards. All right. And as discussed, after calling for help, the first maneuver you will do, and realistically the only maneuver you will do as a junior team in the obstetric team, is to commence McRoberts maneuver. It's highly effective in up to 90% of cases. This helps to deliver the baby, and it involves hyperflexing the mother's legs, so basically bending the knees up towards her chest as much as possible, and then applying pressure just behind the symphysis pubis to help guide the anterior shoulder of the baby out through the birth canal. After that, you will likely require an episiotomy, not necessarily to increase the space for the baby to descend through the birth canal, but actually to be able to manipulate more using a hand. So we'll have a look at the various maneuvers that can be attempted after McRoberts has failed. Realistically, you will never do these as a junior doctor, but they do come up in MCQs. Okay, so Alan Rubin, an American obstetrician who was active in the mid 1950s especially, devised two maneuvers that can help to guide the baby out of the birth canal after shoulder dystocia has happened. The first one is a gentle kind of rocking of the fetal shoulders to try and dislodge that anterior shoulder from behind the symphysis pubis. So quite a gentle kind of intervention comparably. And then the second one is to try and squeeze the shoulder in towards the baby's chest, so adducting the most accessible shoulder to try and reduce the overall circumference of the baby's body, and then to allow exit of the baby through the birth canal. And he was, of course, very proud of his interventions, as I showed you there in the quote. Okay, another maneuver which will only really be possible following an episiotomy is a wood screw maneuver. And this one involves rotating the posterior shoulder, so the one that's not stuck, counterclockwise. And it involves a 180-degree turn clockwise. And the key thing is, again, to dislodge the anterior shoulder from under the symphysis pubis and allow a smooth descent of the baby. So I think it's just to be aware of the name of these different maneuvers and in what sequence you would instigate them. The Zavanelli maneuver is very, very rarely used. It's a last resort, and if all maneuvers previously attempted have failed, then Zavanelli maneuver is something to instigate when there's likely going to be some damage to the baby in terms of neurological damage already, but still you want to try and deliver the baby as quickly as possible. It involves kind of reversing the birth process, so pushing the head of the fetus back through the birth canal in anticipation of performing a cesarean section. So pushing the head back involves first rotating it back to an OA position, so a reverse restitution, and then flexing the neck and pushing it backwards through the birth canal, preparing for going to the operating theatre and delivering by cesarean section. Through these absolute key topics of preeclampsia, eclampsia, and HELP syndrome, which are really, really the some of the key obstetric emergencies that you'll both see on the ward, and you'll be asked about them in your exams at multiple times. Okay, so preeclampsia, it's a very common condition. Somewhere between around 1 in 20 pregnancies is affected by a degree of preeclampsia. And considering it's so common, I am always surprised to find that it's such a poorly understood condition. It's one of the reasons I decided to do my research in obstetrics, because there are these conditions that affect so many women and so many newborns and have long-term effects on the newborn often, but that are so poorly understood. We know a lot about the clinical features, but not so much about the pathophysiology. So it's typically seen after 20 weeks of gestation, and the classic triad of preeclampsia consists of high blood pressure, proteinuria of more than 0.3 grams, so that tends to be 3 pluses on the dipstick, most commonly, over 24 hours. And the classic triad used to include features of edema as well, although that's quite non-specific, and I'm sure that those of you who have started on obstetric placements will find that it's quite common for women, even in a normal pregnancy, not complicated by preeclampsia, to look very fluid overloaded towards the end of pregnancy and feel a bit kind of swollen. So edema is a relatively non-specific sign, but you can see it in severe cases. It's obvious when someone is edematous. Okay, and as you probably understand from picking up that it's a condition associated with proteinuria and hypertension, a key organ that is failing in preeclampsia are the kidneys. Yeah, the kidneys should not be releasing protein into the urine, and the kidneys are of course key in regulating blood pressure, and so it involves a dysregulated renal response, and therefore it's understandable that a key risk factor for developing preeclampsia are any conditions that affect the kidney, including chronic kidney disease, any hypertensive disorders, which of course predispose you to high blood pressure, which is part of the preeclampsia triad, and also autoimmune diseases. Again, these often have kidney involvement as well, so systemic lupus erythematosus is one. Family history is a risk factor, as is it being a woman's first pregnancy or a pregnancy in a woman who is older than 40. So at UCLH, for example, all women who are over 40 will deliver their babies on the labor ward rather than the less interventionist, say, birth center, where people can be monitored a little bit more. And that's partly because preeclampsia is more common in older women. Obesity, as always in today's world, this is obesity and high BMI are seen in most specialties of medicine, and it does predispose to preeclampsia. Multiple pregnancies, so carrying twins or triplets, is also a risk factor. These are really, really common as MCQ questions, so being able to identify risk factors for preeclampsia is really important. Okay. Management. So this was one of the SBAs for a person who has risk factors for preeclampsia, especially if she's had preeclampsia in a previous pregnancy, if she's got chronic kidney disease, hypertensive disorders, or any of those kind of key risk factors for preeclampsia, then we do have quite a low threshold for starting someone on low dose aspirin. So yeah, that kind of maintenance dose, low dose aspirin once daily from really the booking scan, about 12 weeks, if the person is considered being of moderate to high risk of preeclampsia. Naturally, when you think about the triad of preeclampsia as being hypertension, proteinuria, and edema, treating the hypertension early on is absolutely key. And labetalol, as you'll probably come to learn through this year, is the most used antihypertensive in pregnancy. Just bearing in mind that many of the SBAs that you'll be asked will have some sneaky little mention of a woman having a history of asthma or something like that, so that she wouldn't tolerate labetalol. But for most cases, labetalol is the drug of choice. And then, as I mentioned, this is still quite a poorly understood condition, and we don't have any definitive management apart from delivering the baby. And if preeclampsia happens early in a pregnancy, this of course means that the baby will potentially be born prematurely. If the preeclampsia is severe, it might mean that you don't have time to, for example, give steroids to promote lung maturation in the baby. And so there are potentially quite significant long-term consequences of this condition. So I urge you all to consider doing more research into obstetric conditions, including preeclampsia. Does that sound okay so far? Do let me know if you have any questions before we move on. So I got a question here: for women with asthma, which have antihypertensive is indicated. So typically, you can use hydralazine and nitrates. Yeah, hydralazine and nitrates is the kind of probably the first choice option. Is preeclampsia a condition of Western cultures? I also got as a question. Good question, and no, not at all. So common all around the world, and it is more common, as I said, in first-time mothers. It is common also with those risk factors mentioned. Yeah, it's common all around the world. Has no it's not only here in our Western societies. What's the hypertension threshold? So typically it's a systolic blood pressure of above 140 that we consider as hypertension, just as in clinics normally. So the hypertension, the threshold for treating is 140. I know that some of the guidelines say 160, but that is, I've never seen in practice that you allow a woman to go with a blood pressure of 159 systolic without it being treated. So 140 is really the threshold. What is the 20-week mark for? So it simply is the fact that that preeclampsia is more commonly seen after 20 weeks. In someone, and we'll discuss this next week when we talk about hypertension in pregnancy, if someone has high blood pressure in early pregnancy, it is much more likely to be a pre-existing hypertensive disorder, because most commonly blood pressure actually goes down in the beginning of pregnancy. So you'd expect someone in early pregnancy to actually have a lowish blood pressure. And if someone in early pregnancy has a high blood pressure, then it's much more likely that she already had pre-existing hypertension. So a 20-week mark, it is partly because preeclampsia rarely develops in the first half of pregnancy, and also if someone's hypertensive in the first part of pregnancy, then it's more likely to be pre-existing hypertension. Okay. So loads of good questions there. Thank you so much for asking those, and I think many of your peers will be happy that you've asked them, because it's always the case when you bring these things up. All right. Well done, everyone. So I'll move on. So one of the questions concerned eclampsia and severe preeclampsia. So I'd like you to think about preeclampsia and eclampsia as this kind of almost continuous syndrome. So eclampsia can be really easily defined as severe preeclampsia plus seizures. Yeah, so treating preeclampsia and severe preeclampsia will hopefully mean that a woman does not progress to eclampsia, where the absolute defining feature is seizures. I discussed this with one of my obstetric consultants, and he's been working with as an obstetric physician for over 40 years, and he says he's never actually seen, like he's not seen in first person a seizure ever, but he's heard of many people having them. So they seem to be elusive. So typically I'd still like you to think about eclampsia as preeclampsia plus seizures. Yeah, and these women will most likely be quite edematous. Again, it's a non-specific sign, but if someone is severely edematous, then that's a likely part of kind of progression of preeclampsia in towards severe preeclampsia or eclampsia. I've got another question here just before we move on. One of you saw a patient in early pregnancy who said she's only started having hypertension since becoming pregnant. Before it, her blood pressure was normal. Would this still be pre-existing hypertension or pregnancy induced? Well, so it's, again, I mean, there's individual variation everywhere, and we'll discuss hypertensive disorders in pregnancy in more detail in our next tutorial next Tuesday. But as a very general thing, it is uncommon for women to develop high blood pressure in early pregnancy if they didn't have high blood pressure before, because typically in the first part of pregnancy, your blood pressure actually decreases. Yeah, so it might be an individual case, it might be a kind of measuring difference or a white coat situation. I don't want to comment on individual cases without really knowing the history, but very typically, and also for the purposes of your MCQs and going forward, someone who has high blood pressure in early pregnancy, it would be most likely that she actually had high blood pressure before, so it's pre-existing hypertension. Obviously, if it is if it has been measured objectively before and then she has high blood pressure in early pregnancy, then she might be an unusual case of developing high blood pressure early in pregnancy, but it is definitely unusual. Yeah, I hope that's okay as an answer. Okay. Thank you. Excellent. All right. And the last bit of this little section with preeclampsia, eclampsia, and HELP syndrome surrounds this HELP syndrome, which is also, I think, best thought about as a continuum on the preeclampsia spectrum. So it is a form of severe preeclampsia that have these other parameters, which are very helpfully summarized in the acronym HELP. Yeah, so I've colored them there in red. So HELP syndrome is preeclampsia with hemolysis, so hemolytic anemia, elevated liver enzymes, and low platelets. Yeah, so very easy to remember because the acronym is there in the name. Yeah. And commonly in your MCQ questions, they'll talk about someone who has features of preeclampsia and then also complains of epigastric pain. They might be pale, have shortness of breath, or other signs of anemia. And then on their blood tests, they'll have elevated liver enzymes. So HELP syndrome is just another syndrome to be aware of on this spectrum of preeclampsia and severe preeclampsia. And these women are often admitted to hospital, given blood transfusions as needed because of the hemolytic anemia, and bed rest is often quite indicated for these women. They are considerably more unwell than someone with, say, mild preeclampsia. Okay. And epigastric pain is often a distinguishing feature as well. Okay, so we have one more question here. Will they prevent with these on top of the seizures? Sorry, I'm not entirely sure what the question, will they prevent with these on top of the seizures? So just to mention with regards to the seizures, the key management of seizures is IV magnesium sulfate. And IV magnesium sulfate is both to prevent seizures from happening in the first place, but also once seizures do happen, they help to terminate the seizures, and they're continued for 24 hours after delivery. That was one of the questions. And because of this fluid overload and edematous picture, these women need to be very carefully monitored in terms of fluid balance, and overloading them with fluids will just cause the condition to get more severe. So keeping a very strict fluid balance, not giving too much IV fluids, but giving magnesium sulfate for seizure prevention and control is the key management of severe preeclampsia and eclampsia. Now, if someone's got severe preeclampsia, you start the magnesium sulfate without waiting for the seizures to occur. So that's a key thing to realize, that magnesium sulfate can prevent seizures from ever happening in the first place. Okay, so I hope that answers the question. I didn't 100% figure out what the question was, but I hope that gives an answer. I've got another question here. Are women who have HELP syndrome more likely to develop eclampsia, or is it the same risk as those with a less severe form of preeclampsia? So the women with preeclampsia are much more likely to develop HELP syndrome. So I'd like you to think of HELP syndrome as a severe form of preeclampsia, or something that severe preeclampsia can progress into. So you wouldn't go from completely healthy normal pregnancy to HELP syndrome. You would be much more likely to progress through preeclampsia, severe preeclampsia, HELP syndrome. Okay, if you've got HELP syndrome, that is separate from eclampsia proper, but they can occur in the same person. So obviously, if you have developed severe preeclampsia, you can have a situation where you develop both low platelets and hemolytic anemia and seizures. I haven't seen this combination of syndromes myself, but because the risk factors are similar, as in preeclampsia and all of the risk factors for preeclampsia, then most likely this will very much be possible that they happen at the same time. Again, 5 years on labor ward, I haven't seen it, but yeah, logically, yes. Okay, thank you. Okay. Let's move on to our third topic, which is about postpartum hemorrhage and major obstetric hemorrhage. Okay, so primary postpartum hemorrhage, the textbook definition here is loss of 500 milliliters of more or more of blood vaginally within 24 hours of birth of the baby. Okay, so more than 500 milliliters. That's the kind of definition, yeah. Very common, so affects about 1 in 20 of deliveries. Can be divided into minor and major postpartum hemorrhage. And if there's between 500 and 1,000 milliliters, so up to a liter of bleeding, then it's defined as a minor postpartum hemorrhage, and major is if you're above that threshold of 1,000 milliliters. It is a major cause of maternal death worldwide. So again, I'm encouraging everyone to go into obstetric research and patient care, because there's a lot to do. Risk factors for this quite logically includes previous postpartum hemorrhage, prolonged labor, preeclampsia, polyhydramnios. Does anyone know what polyhydramnios is briefly? If you want to pop it into the little chat box, do you know what polyhydramnios is? Exactly, yeah. Excess amniotic fluid, yes, yeah. And typically it's picked up prenatally by someone whose uterus grows more than expected per week, or is kind of larger than expected growth per week. Yeah? Too much amniotic fluid. So polyhydramnios, obviously it means that the uterus is more distended than expected at a particular point in pregnancy, yeah, and this predisposes to postpartum hemorrhage, and placenta previa, which we'll go through in a second. A key thing to remember with regards to postpartum hemorrhage are the 4 T's, which are the 4 key causes of postpartum hemorrhage. These you'll hear midwives talk about all the time, and they will be frequently examined in your SBAs at the end of the year. The 4 T's are tone, which is the vastly the most common cause of postpartum hemorrhage, and that refers to atonia of the uterus. It basically means that the uterus doesn't contract properly after delivery of the baby. Yeah, that's the absolute key risk factor, or cause rather, of postpartum hemorrhage. So tone. Tissue means that you have some retained products of the placenta sticking to the uterine wall and bleeding from those products of conception still stuck. Some of you who've done your obstetric placements will probably remember midwives very well in detail examining the placentas after the 3rd stage of labor. So really looking in detail at every little segment of the placenta, making sure that there's no place where the placenta looks incomplete and where there's a little bit of the placenta still stuck inside the uterus. So tissue refers to retained products of conception. Trauma, of course, things like episiotomies or major tears during delivery absolutely predisposes you to hemorrhage. And thrombin refers to any kind of blood coagulation abnormalities, lack of clotting factor. So most likely this will be known already before the delivery, but if the woman has a bleeding disorder, then obviously this predisposes her to postpartum hemorrhage. Okay, I've got a really good question here. How does the polyhydramnios result in hemorrhage pathophysiologically? So I'd like you to think about the maternal spiral arteries, which you might have read about, and how the spiral arteries are remodeled into these very kind of distended vessels that go into the placenta and deliver well, via the umbilical cord, oxygen and nutrients to the baby. So those vessels from the maternal spiral arteries, they contract and stop bleeding when the uterus contracts. Yeah, so the key thing that has to happen in the third stage of labor is that the uterus contracts, and that will stop the bleeding because it basically squeezes the spiral arteries shut. That's how I think about it. Yeah, if you've got polyhydramnios, it means that your uterus is likely to be more distended than it should be at any given moment. So you'll have a uterus that is full of extra amniotic fluid. The uterus will be of a larger size than it should be, more distended than normal. And it means that with a large distended uterus, it will be more difficult to get it to contract. And so more difficult to get the blood flow from the spiral arteries to stop after delivery of the baby. So it's a kind of a stretched situation. That a large distended uterus is more difficult to contract and therefore more likely to bleed compared to one not affected by polyhydramnios. Yeah? Does that make sense? I hope it makes sense. So I'd like you to just imagine what's going on there in the uterine wall with these maternal blood vessels that insert into the uterine wall. Okay, great. Thank you. Great. Lovely. So going through the management of postpartum hemorrhage, I know many of you were absolute pros there with knowing that uterine massage is one of the first things to do, especially in a hemodynamically stable woman who is affected by postpartum hemorrhage. Obviously, this is, and I mean, this is key for all obstetric emergencies. You need to start with resuscitating as indicated. So you go through your Dr. ABCD, just like with any emergency on any other ward: airway, breathing, circulation. A key thing is going to be to think about, do you need fluid straight away? Do you need to insert your 14G cannulas? And do you need to ask for that cross-matched blood, which should be available for rapidly for women? Do you even need to give some ONEG blood if there's no time to get cross-matched? So resuscitate as indicated if needed, but in a hemodynamically stable woman, you'd start by performing some bimanual compression, some massage, and making sure that you kind of allow the uterus to contract as well as it can. So things like catheterization can help, an in and out catheter. And then you start your IV Synto, and you can give up to 10 units. So I think this is what the question was referring to, that you can give a continuous IV drip of IV Syntocinon rather than just giving that quick little Synto IM dose up to 10 units. And then I've not seen ergometrine used in UCLH. It was much more commonly seen to use. Much more commonly, I saw various prostaglandin analogs used. So I think it differs a little bit between different hospitals. So just look into local guidelines and what the green top guidelines say right now. But ergometrine or prostaglandin analogs come after the Syntocinon. And then if your medical management has failed, then the first so-called surgical step in your management of postpartum hemorrhage is to insert a balloon, an intrauterine balloon tamponade. I have a picture to show you what that is for those of you who haven't seen one. And this is quite a commonly used method. I'll show you in a second. Okay, and the very, very last resort is a hysterectomy. Okay. So here are a couple of pictures just to show you what the intrauterine balloon tamponade refers to. You essentially insert what's a small balloon into the uterus, and then you fill it with fluid, so normal saline or water, to try and you basically press the balloon against the uterine wall to stop the spiral arteries bleeding into the uterus more. So it's a real just mechanically stopping the blood from flowing from the uterine, the spiral arteries. Okay, and then you slowly, once the woman stops bleeding, you reduce the size of that ball by taking out the fluid from the ball and making sure that the bleeding doesn't restart. A B-Lynch suture is effectively a way to reduce the size of the uterus. So you kind of try to compress. If the uterus is atonic and it doesn't contract properly with your Synto and all your bimanual massage, etc., then a B-Lynch suture, as shown there in the picture, effectively just helps to contract the uterus. Okay. So I think we're getting towards the very end of this tutorial. The last things we'll discuss today are placenta previa and vasa previa. So the first thing, vasa previa, it effectively means that the vasa, or the vessels, are that they cross the internal orifice of the uterus. So basically just above the cervix there, they cross the internal orifice of the uterus. And this means that when the membranes rupture, you can get bleeding from these vessels that are right there at what will become the birth canal. Yeah. And the key thing to recognize that then is that because the vessels, the fetal vessels, are those which supply oxygen and nutrients to the baby, that if those vessels bleed, then the baby will be in distress, right? So in your SBAs and in your clinical attachment, you'll hear and read about women who present with abnormal CTG, or they have an abnormal CTG trace. They'll have painless vaginal bleeding, so typically painless vaginal bleeding. And most likely in this country, this will have already been picked up on earlier scans, but sometimes things can move around and it can happen late in pregnancy. So yeah, the key thing to bear in mind here is that you'll have an abnormal CTG trace most likely, and painless vaginal bleeding. Okay, and it's associated with what's called velamentous insertion of the cord, which I've shown there in the picture. And that effectively means that the cord insertion is not centrally located in the placenta. So typically in the placenta, and a more effective way of the placenta working is that the cord insertion is more or less at the center of that round placenta. Yeah. I have just for information, I have spent a good 5 years taking small pieces of placentas from varying distances from the insertion of the umbilical cord, and it's a joyful experience. But but a cord like the one in the picture would be tricky. It would be tricky to know exactly where the center of the placenta is, really, because the cord is so far off where it should be. But velamentous insertion of the cord, as pictured there, predisposes you to vasa previa, painless vaginal bleeding. Typical symptoms. Okay, and then a different condition, but a similar sounding name, is placenta previa, and this is rather than having just the vessels pass through or across the internal opening of the uterus, you have the actual placenta lying wholly or partly in front of the orifice. Okay, so the placenta is wholly or partly in the lower uterine segment, and it can be classified as major or minor. There are different classification systems. You might read about grades or types or something like that. But I think it all makes sense if you have a look at the pictures here. You can see that in picture A, you have a low-lying placenta that is very close to the internal os, but it's not actually traversing the internal os. So this is unlikely to cause any major concerns. It might cause a little bit more bleeding at delivery, but that woman, the hypothetical woman who has uterus A, will be most likely able to deliver vaginally. In B, you have a minor or a partial placenta previa, where a small part of the placenta lies in front of the internal os. This would probably be where you start thinking about if it's safer with a cesarean section rather than a vaginal delivery. But definitely in C, in a pregnancy where a placenta lies like you see in C, where most of the placenta lies, or a big part of the placenta covers the internal os of the cervix, then delivery via cesarean section is definitely strongly indicated, because this would be a risk both for mother and fetus to try and deliver vaginally with a placenta kind of covering the internal os of the uterus. Okay. This should be detected on antenatal ultrasound scans. A transvaginal ultrasound may be required to confirm if it's not immediately obvious, or if it's a minor case of placenta previa shown on an abdominal ultrasound. And these women will present with vaginal bleeding towards the latter stages of pregnancy. Typically, it's painless vaginal bleeding, again, just like vasa previa. Yeah. So previa, basically think of it as either placenta or cords blocking the internal os of the cervix. Yeah. Excellent. Okay, so looking at the management of placenta previa, as we saw on the previous slide, the key thing to recognize is that if a woman is diagnosed or is seen to have placenta previa in late pregnancy, so 36, 37 week onwards, then delivery by cesarean section is definitely indicated. And if it's only a minor part of the placenta that covers the internal os, she might be able to deliver vaginally, okay? So it's always an individual decision. If a woman presents during pregnancy and has vaginal bleeding plus a placenta previa, then admitting her, suggesting bed rest to avoid more bleeding, because if you think about it gravitationally, it will help with bed rest. Cross-matching blood to make sure that she can have a transfusion if needed. And also, this is a time when you would not do a transvaginal examination, because that's when you can risk causing more bleeding by damaging the placenta from your examination. Okay, so admit, cross-match blood, and avoid doing a transvaginal examination. Delivery is most likely going to be by cesarean section. Okay, I think this, we have two small topics to go. Placental abruption is one of them. And I think the key thing to remember here is the picture showing the separation of the placenta from the uterine wall. Yeah, so typically those two are stuck to each other, but the placenta has started separating from the uterine wall, and there's bleeding underneath. So as discussed previously with postpartum hemorrhage, we're talking about heavily vascularized organ or structure here. And as soon as the placenta starts separating from the uterine wall, those maternal spiral arteries are going to bleed heavily into that space. And you might bleed, or the women who are affected by this might bleed so much that they will go into hemodynamic shock without you noticing that much blood loss. So 80% of women will have some vaginal blood loss, but it's likely to be out of keeping or disproportionate to the hemodynamic instability. Okay, placental abruption affects around 1 in 200 pregnancies, and risk factors include maternal hypertension, cocaine, trauma, tobacco, and previous placental abruption. So all quite logical risk factors there. Women will present with lower abdominal pain, a tense, tender, woody uterus. It might be difficult to hear fetal sounds, because it's basically the sounds are interrupted by this bleeding or blood between the uterine wall and the placenta. And the fetus might show signs of distress on CTG. So you might have an abnormal CTG tracing because the fetus is not getting the amount of oxygen and nutrients. Oxygen is the key thing that the fetus needs. Okay. And I've put there as a note to recognize that placental abruption is typically painful, whereas placenta previa is typically painless. Someone asked here, why does the uterus become woody? So it's, I don't know if you remember from when you looked at respiratory examinations, and they say that effusion or massive effusion is associated with stony, dull percussion note. Is effectively that. So you have a lot of fluid accumulating inside the uterus, and so when you feel the uterus, you won't feel fetal movements, you won't feel that kind of movement of amniotic fluid and fetal movements that you normally feel. Instead, you just feel this kind of stony, dull, woody uterus, which is effectively just you feeling this blood that has accumulated between the uterine wall and the placenta. So woody is just an adjective to describe that kind of stony, dull type sensation. Yeah, so it's just the blood. All right. Okay. And management is fairly self-explanatory. Obviously, you start to resuscitate, and your key priority is always, resuscitate the mother first, and then consider what you can do to make the pregnancy continue or to deliver as safely as possible. Placental abruption is an indication for an emergency cesarean section. Yeah, but you need to resuscitate the pregnant woman first. Last topic, I promise this is the last topic. And so compression, I mean, it can happen when the baby kind of rolls around and twists the cord around his or her neck, or it can be when the cord is compressed between the internal os and the presenting part. But in either case, it's going to be associated with CTG abnormalities in the majority of cases, and it is an indication for emergency cesarean section. Okay, so that is actually all the topics I'm going to talk about today. I know that I've ran a little bit over time, and so I'd like to thank you all for joining today, and for all your really, really good questions. And I've put up my email address there if you'd like to email me any questions.